Yes, so we can start.
File.
Yes, yes. We can begin, sir.
Yeah. Start, madam.
Okay.
Yeah.
Good afternoon, everyone. We welcome you to this webinar. A special invite today with us is Dr. Pramod Jog. So let me brief you through our company, which is Hetero Healthcare. So next slide, please. So, Hetero Healthcare is an innovative pharmaceutical company, as you all know. And with that, our journey began in 1993, having 30 years of excellence, 300 plus products in portfolio, 21,000 employees globally. It is amongst the largest manufacturers of ARV, APIs, and FDFs in the world. 36 state of art manufacturing facilities, presence in 126 plus countries, and largest closely held pharmaceutical company in India. It is also known as Asia's largest API manufacturing at SEZ Complex, Vishakhapatnam, Andhra Pradesh. And not only that, with that, Hetero is a 360-degree solution provider which strives to fulfill the unmet healthcare needs, reaching to customers across India, wide product range encompassing multiple specialities, pioneering in equality and innovation. Distinction of bringing four biosimilar products to market within 5 years of initiation, that is darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare was the pioneer in antivirals, as you all can see, Fluvid, Favivir, and Covifor. So, with that, we are very proud to say that we were awarded as Pharma Excellence in August 2020 for COVID drugs, and we are very proud of it, and we continue to do so and touch many such lives. And that's why today we have this particular webinar where I think Dr. Pramod Jog, excellent in his field, is going to throw some light on the rational approach in respiratory infections. So we welcome you, Dr. Pramod Jog, and we are very delighted to have you here with us.
Welcome, sir.
Dr. Pramod Jog is MD, MNAMS, FIP, FIMCH, PG Diploma in Pediatric Infectious Disease, Best Performer at ADVC France 2011. He's MA in Sanskrit, Proficiency in French and Spanish, Director Womb to 18, Professor of Pediatrics at DY Patil Medical College, Pune, National President, Indian Academy of Pediatrics, AIP 2016, Standing Committee Member, International Pediatric Association, Steering Committee Member, GAVI, Standing Committee Member, ASPID, Consultant Pediatrician, MediPoint, Jupiter, Ankura, New Sanvi, and Dinanath Hospitals. He is a senior consultant to UNICEF and also a member at Maharashtra State Pedia COVID and Measles Task Force. Sir, we welcome you all, and I'm sure with your knowledge and your clinical experience, we are going to have a wonderful session ahead. Over to you, sir. Thank
Oh,
you.
thank you. Thank you. I will start sharing my screen.
Yes, sir.
Just tell me. Yeah. I hope I am visible and audible, right? Yeah. So the slides are seen, huh? Okay.
Yes, sir.
Yes.
Very good.
Yes.
Okay. So today we will be discussing a very, very important topic, and that is rational approach to viral respiratory infections. Now, why this is important? Because many of our colleagues, they get patients of cold, cough, and fever day in and day out. In fact, I would say cough, cold, and fever, these are the symptoms which I would call as the bread and butter of the practicing pediatricians. And whenever a pediatrician faces such a patient, there are various things which come to the mind. The most important is whether it is viral or bacterial. If it is viral, what is the type of virus? If it is bacterium, what is the type of bacterium? Whether I need to treat him immediately, whether I need to give antibiotics or antivirals, and so on and so forth. So many questions come, and it is possible that our colleagues are not very, very clear about some of these concepts, which are very, very important in the field of pediatric infectious diseases. So, what one should remember is that the range of severity is from very mild to very severe, and many times the infections are treated irrationally. Why I say so? Because let us imagine a child who has come to the OPD with red throat. Okay. Now, it is possible that this child has either viral infection or bacterial. But if the pediatrician is not very clear as to whether it is viral or bacterial, he commits a mistake on the side of taking it as a bacterial infection and gives either amoxicillin or amoxiclav. Now, if I ask him a question, why not antiviral like oseltamivir? Then he doesn't have an answer. So it is important to note that almost 80 to 90% of the infections in the respiratory tract as well as in the GI tract are viral in nature. So when a child comes to you with cold, cough, and fever, please remember that there are high chances that the infection is viral and not bacterial. So antibiotics on many occasions are not necessary. That is number one. Now, the most important thing is that after COVID, children they started getting different kinds of viral infections. During COVID, children stayed at home, adults also stayed at home indoor, and adults as well as children, they did not develop any immunity against certain viruses. So we witnessed that after mid 2022, when COVID pandemic started declining, children started presenting with either hand, foot, mouth disease or respiratory syncytial virus disease, or in some areas where measles immunization was on the lower side, they started getting measles and so on and so forth. Even today, we have been witnessing, the viral infections at a higher frequency. So one of the reasons as to why viral infections are seen in an increasing proportion is absence of immunity in the post-COVID times. This is something one must remember. And in fact, when your parents come to us and ask us, sir, why my child is getting repeated respiratory infections, it is important that we tell them that the immunity of the child during COVID has been on the lower side, and that's why now he is showing up with some of these viral infections. Okay, let us see a very, very common case where a 6-year-old girl who attends the daycare presents with rhinorrhea and cough for 8 days. The cough is only during the daytime, and she had fever for 2 days, and the appetite is poor. On examination, there is a clear discharge from the nose, and rest of the examination is unremarkable. So obviously, remember, whenever a child is brought with simple runny nose with maybe a mild fever of 2 days, this is almost always viral, and this is common cold. Now, there are different pathogens which which start their journey with cold. So, whenever parents say that, sir, the onset is with cold, runny nose, in fact, I used to be relatively relaxed because then I knew that this child has a viral infection and I did not bother much about it. That was a story long back. But then, after 2009, when we witnessed the H1N1 pandemic, and after this COVID pandemic, viruses have given us a very, very bad time. And that is why these days, even though in the beginning, I am, little bit, relaxed that it's viral and I need not worry. I always tell the parents that after 4 or 5 days, some of these viruses can change their course, and then there could be, some problem which we know, like a cytokine storm, which can come up after 4 or 5 or 6 days, and the child may present with a different kind of a picture where it could be a serious picture. And that's why it is important that we call our patients for a second visit somewhere around fourth or the fifth day, or if the child worsens during course of the viral illness. This is very important. Of course, I do not charge the patients for their follow-up visit because when patients are brought for the second visit for a recheck, I am learning. Okay, so that should be the lookout of the pediatricians, that you are learning. And that's why, in case if you want to learn, you see that almost all the patients who come to you on day 1, they come back to you on either day 4 or day 5, so that you know whether everything is going fine. Okay, and once the patients are reassured that they need not pay for the this follow-up consultation, then usually they come and show the child to you. So this is something one can practice as a routine. So there are certain pathogens like rhinovirus, the coronavirus, the respiratory syncytial virus, human metapneumovirus, influenza virus, parainfluenza virus, adenovirus, enteroviruses like Coxsackie A. And if you see, each of them have some specialty. For example, when you get respiratory syncytial virus, it will produce bronchiolitis, and this is common in children under the age of 2 years, particularly under the age of 1. Influenza. This is the father of all influenza-like illnesses. What do I mean by influenza-like illness? Where there is cold, cough, and fever. But influenza will produce severe headache. The child will have weakness. The child will have muscle pain. So when an older child, say around 8 or 9 or 10-year-old, is literally lifted by the parents and brought to the clinic, it means that the child is really unwell. So though he has viral infection, it's not mild, and that's why influenza in a particular setting, that means when there is influenza epidemic in the atmosphere, when all other colleagues are witnessing cases of influenza, it is important that you take out or classify or triage these patients in the OPD, where you can instruct the receptionist that, see, if there is a child who has high fever with chills, who has headache, who has muscle pain, who has weakness, then please see that the child is brought to my notice, and I many times then I tend to diagnose it as influenza. This is important. There are viruses like parainfluenza which produce presentation like croup. Adenoviruses are a different ball game, and they produce pharyngoconjunctival fever, but they can have in addition mesenteric lymphadenitis and hemorrhagic cystitis and some other non-respiratory presentations. And enteroviruses like Coxsackie A can produce ulcers on the back in the oral cavity, which are called as harpangina, which is extremely painful. And I will show you one picture in the latter part of the presentation. Okay, so this common cold, which I told you in the first case, it averages about 6 to 8 per year, and basically 10 to 15% of children, they get about 12 infections per year, and the incidence of the illness decreases with increasing age, about 2 to 3 illnesses per year by adulthood. And children in the out of home daycare centers during the first year of life, 50% of them have more incidence of colds than children who are cared at home. Okay, and what all these children they get is a scratchy sore throat with a nasal obstruction, a runny nose, and about 2/3 of the children have cough, and the cold may last for 1 or 2 weeks, and the child will have fever and constitutional symptoms like weakness and loss of appetite. And remember, there could be a change in the color or the consistency of the secretions, which is very common. So if the white discharge turns into yellow, it does not indicate bacterial superinfection. Remember this, okay? And the nasal turbinates, that means when just ask the child to lift the head up and look into the nasal cavity, there on the lateral side of the nose, on the inner side, there are some nasal turbinates which are swollen and red. Okay, treatment is very simple. It is supportive with an anticipatory guidance that, see, this child is almost likely to have a viral infection which doesn't need antibiotics, and there is only need for adequate oral hydration, and then warm water, and then maybe saline instillation, and one need not even use cough and cold products for infants or children who are younger than 6 years of age. Okay, here one must remember that the first generation antihistaminics may reduce the rhinorrhea, and vitamin C and inhalation of warm humidified air, they are used by many of the parents as well as the colleagues, but then they are nothing more than placebo in the treatment of cold symptoms. This graph is extremely important. What you would see is that there are two lines. One is red and other is yellow. The red line is related to the fever. So in the initial 0, 1, 2, 3 days, the fever is on the higher side. And as the illness progresses, fever comes down and almost disappears. But the respiratory symptoms are not present in the beginning. They start somewhere on day 3 and 4 when fever is coming down, and they persist for about a week, and then they start going down. Why this graph is important? Because many parents tell you, sir, this child has fever, cold, and cough. So you give them paracetamol, you give them maybe antihistaminics, and then you feel that everything should be fine. But on day 4, mother calls you, says, fever has gone down, sir, but the cold and cough have started. Then after a few days, she says, sir, the cough has increased. So what are those children where cough increases after 7, 8, or 9, or 10 days? These are the children who have hyperactive airway to some extent, okay? Or there are some viruses, which I told you, like respiratory syncytial virus, that is notorious to produce a bit of bronchospasm. So children who continue to have cough, even after 10, 15, 20, 21 days, 3 weeks, 3.5 weeks, they are the ones who are the ones where there is a bit of hyperactivity of the airways. So remember that this progression of uncomplicated viral URI is very important. Otherwise, in the beginning of my practice, I used to tell the parents, don't worry, your child will be all right in a span of say 4 or 5 days. But then, in some cases, it was okay. But then in some cases, children won't recover after 5 days, not even after 7 days. And then my seniors, they told me, Pramod, remember, whenever a child is brought to you for respiratory symptoms, tell them that it will take minimum 7 days. Okay. Fever will disappear, but cold and cough will continue. And in some patients, the cough, in fact, may worsen. So the parents will bring the child again, but at that time, fever won't be there. Okay. So if the cough increases after 7 days, 10 days, it's a part of the natural course of the disease and it doesn't warrant antibiotics. So neither in the beginning nor at a later date when the cough has increased, you need to give antibiotics, because the cough that has increased is not because of the infection, because it is at that particular moment related to the hyperactivity of the airways. This is something which our colleagues must remember. And now you will ask me, that's fine, sir, but then what are the indicators which suggest that the child is getting serious? So the indications are very simple. One is, of course, that the child will have flaring of the nostrils. The child will have, movement of the neck muscles. Some of these children who are hypoxic, where oxygen saturation goes down below 92%, they can become cyanosed. Okay. There could be retractions. That means the chest wall, will show retractions either in the upper part or the lower part, so on and so forth. And after COVID, many people have pulse oximeters in the house. So tell them, so in case if you have pulse ox in the house, just try to measure the oxygen saturation. And in case if it is less than 92, please come to the medical facility. Okay. Now this child improves for a week or so and then again develops high grade fever with thick mucopurulent nasal discharge. Now, what is this? Remember, whenever the cold continues for about 7 or 8 or 9 or 10 days and the discharge becomes purulent, okay, then earlier I told you that if a child has rhinorrhea, which is watery, followed by mucopurulent discharge on day 5, 6. Okay. But after 7 or 8 or 10 days, there is nasal discharge, which is having a very, very bad smell. It is almost pus. Okay. And the child lies down on the bed and the child starts coughing because there is a post nasal drip. So that is the condition which is called as acute bacterial rhinosinusitis. So rhinitis, which was viral, has now turned into rhinosinusitis, which is many a times, in almost 70% cases, bacterial. And these are the bacteria which are, like Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. Okay. So this is acute bacterial sinusitis where there could be different sorts of presentation. So there could be nasal congestion, rhinorrhea, or cough more than 10 days without improvement. There could be temperature more than 38.5 degrees Celsius for 3 to 4 days with purulent rhinorrhea for 3 to 4 days. Or there could be return of the symptoms after initial resolution with new or recurrent fever, increase in rhinorrhea, or increase in cough. Okay. And as I told you, the bacterial infections, particularly Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella, are the bacteria. Okay. Three important bacteria which trouble the respiratory system, and they are usually treated with amoxicillin or amoxiclav. The point to be remembered is that the medication is to be given for 10 to 14 days. That is because the eradication of these organisms takes longer, because these are in the sinuses, which are deep cavities. Same is true for otitis media, miliary cavity, deep-seated cavity. So duration of therapy will be for 14 days. Let us see another case, a 6-year-old boy with fever, throat pain and vomiting. See, the child has throat pain, okay? And you see that the tonsils are swollen and red, and the cervical nodes are tender. So obviously, remember, whenever you have fever, throat pain with swollen red tonsils and tender nodes, this is acute tonsillopharyngitis, okay? So you can see that the tonsillar area is red, and here comes the important point of differentiating viral from bacterial. Many of our colleagues, they are confused, and they don't know as to how to differentiate viral from bacterial. So I will tell you, in a child, when a child comes with cold and cough, but in addition has other system involvement, for example, the same child has vomiting and diarrhea, the same child has rash, the same child has red eye, then it means that more than one system is involved in this child. That is viral. Number two, in the family, Dr. Jog is unwell, his wife is unwell, his children are unwell, more than one member in the family unwell, viral. And in the community, that means the society where I stay, my family is unwell, Dr. Joshi's family is unwell, Dr. Khan's family is unwell, Dr. Chordia's family is unwell. So all are unwell, all families, more than one family in the community, viral. So more than one system in a child, viral. More than one member in the family, viral. More than one family in the community, viral. Very simple. Secondly, you give paracetamol for a child with cold, cough, and fever. Fever comes down, and the child starts playing for the next 6 hours. This is viral. That means the child is normal in the interfebrile period, playful. But in a bacterial infection, the situation is different. These infections are usually localized. Just as I showed you in the earlier picture, the infection is localized in the tonsillar area. This child won't have red eye, this child won't have rash, this child won't have diarrhea, this child won't have pneumonia. So only infection of the tonsillar area, localized, that is bacterial, high fever, and along with that, this particular child will be unwell in the interfebrile period. Okay, so the mother says that, sir, this child has fever, and I give him paracetamol. After about an hour, the fever comes down, but the child is not his own self. He is still dull. He doesn't play with his brother. Okay, so interfebrile period, the child is unwell. This is typical of bacterial infections, and only one system involved. In a child, you won't have more than one system involvement. So if you remember these 2-3 points, it will help you differentiating viral from bacterial. And of course, in viral infections, you get conjunctivitis, as I told you, coryza, cough, diarrhea, hoarseness. Remember, change in voice and wheezing. Okay, these are also important indicators of viral infection. So when a child comes with cold cough and you auscultate and you get wheezing, then it is almost always viral. Okay, that's why we have a sentence, and I always tell in my other talks that whenever a child has sneeze and wheeze, it is viral. Okay, and in addition, whenever I come across a child who has watery diarrhea, that's also viral. So when we discuss about rational antibiotic therapy, we always say that sneeze and wheeze are viral and watery diarrhea is viral. So in other words, watery nose and watery diarrhea are viral, and one need not give antibiotics. Okay, remember these important points. And of course, in the features of viral infections, one can always have viral exanthema, like in case of measles or chickenpox, where you have rash on the body. On the other side, Streptococcus pyogenes, which is a bacterium, where there is sudden onset of sore throat with fever, headache, and typical age of 5 to 15 years, and tonsillopharyngeal inflammation with patchy tonsillopharyngeal exudates, and sometimes petechiae, small red spots on the palate, and anterior cervical lymphadenopathy, which is tender. Okay, so sometimes children who have streptococcal infection on day 2, they get a rash, which is called as scarlet fever. Okay, and of course there have been some scoring systems for differentiating viral from bacterial. It's very simple. So if there is high fever with tender cervical nodes and tonsillar swellings or exudates, but absence of cough. Okay, so when your child doesn't have cough, it goes more in favor of bacterial. Remember this point. So, and these bacterial infections are common in the age group beyond 3 years. Okay, while in age beyond 45 years, these are not common. So the score of 1 is given. Say in case temperature more than 38 degrees, give him 1 point. No cough gets 1 point. Tender anterior cervical nodes, 1 point. Tonsillar swelling or exudate, 1 point. Age between 3 and 14, 1 point. But if the age is above 45, it goes against the diagnosis of bacterial infections. So this scoring system is used, in cases where there is a bit of a confusion whether it is bacterial or viral. And if the score is 4 or above, then many times, it is taken that it's more likely to be a bacterial infection. Okay. And again, the treatment for tonsillopharyngitis of bacterial origin is amoxicillin. Remember an important point that tonsillopharyngitis also, okay, in 70% cases is viral, okay, and only in 30% cases it is bacterial, and the bacteria remain the same as I told you. Okay, now I will just show you two pictures. So if you just have a look at these two pictures, this picture has a child who is showing you certain important presenting features. What are the features? Here, this child has painful fluid filled blisters or vesicles on the gums, on the lips, on the tongue. If you see on the tongue also, and the inner cheek, which is of course not seen. Okay. And these blisters, they rupture into ulcers. And the common symptoms, they include fever, swollen or bleeding gums, bad breath, the child is irritable, there is drooling and difficulty eating or drinking. And this is what is typically known as herpetic gingivostomatitis. Okay. While the other picture, if you see here, it shows you a condition called as herpangina. What is herpangina? Again, remember, this is a contagious viral infection and it is common in children, and it's characterized by sudden onset of high fever, severe sore throat, painful small blisters, if you can see at the back, okay, and back of the mouth. In the herpetic gingiostomatitis, you could see that they are on the front side. And this herpangina is extremely painful. It is because of the Coxsackie virus. The symptoms, they last for about 7 to 10 days. No antibiotics are required, but many children are horribly, troubled, and, they will cry, they won't eat, to the extent that parents also are extremely worried, and irrational antibiotic therapy many times, is given. But remember, this is all viral, and these children, recover in 7 to 10 days. This is herpangina, okay? And this is related to Coxsackie virus. This is an enterovirus, okay? This is not respiratory virus. This is a, enterovirus. And, when children they come in very close contact, they kiss each other, when there is transmission of saliva and so on and so forth, or they use the same spoons for eating, then these infections, they do occur, okay? So I hope these 2 points are clear. And remember, there are certain situations when you are worried. For example, I told you in the beginning about influenza, and you are not sure whether this child is influenza or something else. Then you can go ahead and try to find out viral etiology. See, it is important that you know when to do the test for viral etiology. So there is a system of grading influenza into 3 grades of A, B, and C. In grade A, the child is usually well, and the symptoms are mild, and there you can simply maintain his hydration, give paracetamol and symptomatic therapy. In grade B, these are the children where, the symptoms are more, the fever is on the higher side, and the respiratory rate is a bit on the higher side. And there are some high risk situations where the child might be having some underlying heart disease or some respiratory problem, or there could be, some people in the family who have problems, like people on steroids, or some asthmatics in the family, or a pregnant mother, or people who are above 65, and children who are less than 5 years, particularly those under the age of 2 years. So all these are high risk categories. So if a child of these categories gets influenza, then it is usually put as grade B. And C, grade C, is where the child is quite serious. As I told you earlier, he has nasal flaring, he doesn't feed well, and then this child is having change in sensorium, is drowsy or irritable. So all these are symptoms of, grade C, severe influenza. Now, one should remember that if he comes across a child of this nature, grade 2 and grade 3, that is B and C, they require antiviral therapy, particularly those who are in the high risk category and those who are in category C. They need oseltamivir, which is an antiviral agent, a neuraminidase inhibitor. Okay, this neuraminidase inhibitor works wonderful when it is given under 48 hours of infection. That means you diagnose influenza as fast as possible within 48 hours, give oseltamivir, and the child will not progress to seriousness. This molecule has quite a few different advantages. One, that it reduces the severity. Number two, it reduces hospitalization. And number three, it reduces the mortality. And during H1N1 pandemic in 2009, this particular medication saved lives of many, many, many patients who suffered from influenza. It is important. However, if you are not very confident about what is the diagnosis and the child is not improving in spite of antibiotics, sometimes, the child presents with high fever and someone has put him on amoxicillin or amoxiclav. 3, 4, 5 days are over. You are worried as to what is the problem. Okay. At this juncture, if the child gets admitted to the hospital, it is prudent and wise to send a throat swab so that you know whether it is bacterial or whether it is viral, and viral, particularly influenza. Because influenza is one of the eminently treatable viral infections. See, all others like rhinovirus, RSV, human metapneumovirus, all these, they don't have these, antiviral agents to help us. And that's why the only one where we have something in our hands is influenza, where we can diagnose it by testing and give oseltamivir. But remember, WHO has categorically said that if you suspect influenza from the symptoms which I told you earlier, headache, weakness, and muscle pain, if there is an epidemic of influenza or if you see more number of cases in the atmosphere, then you are fully justified in giving oseltamivir. You need not wait for the viral PCR results. Of course, in these results, sometimes you get co-viruses. The viruses like rhinovirus, they can, simply be present in the report and they are innocent bystanders in many, many situations. Okay. However, you should go by your clinical judgment. Even if you get some other virus in the throat swab, and if you find that the child is not looking well at all, then use your senses and give oseltamivir. Okay. However, if the test is positive, then remember that in almost 95 to 100% patients, it is influenza. Okay. So false positives are not that common. That means the test is positive and still it is not influenza. It doesn't happen. However, in few, say 20-30% patients, sometimes if the technique is not good or the swab was not collected properly, then the test may come negative. Okay. And even then the child can have influenza. All in all, just remember, go by your clinical judgment. If you find that these are the symptoms suggestive of influenza, there are people around who are suffering from influenza, the society is full of influenza, our colleagues are seeing influenza, the season is June, July, August, September influenza, give oseltamivir. Don't hesitate in giving oseltamivir, because even at that time, more than the bacterial infection, you are thinking of influenza, and that's why oseltamivir is the drug of choice there and not amoxicillin. Why? Because oseltamivir will act only in the first 48 hours. If you make late, the effectiveness of this molecule will not be that much. It will be effective, but then to give it fast is very important. That's why our family physician colleagues who are into the general practice, family practice, it's their responsibility to remember all these points and start oseltamivir on time. Okay. Let's see another case where there is a 3-year-old child who visits emergency room at 2 a.m. in the morning with history of sudden onset of breathing difficulty. Okay. He is restless and there is a stridor. What's a stridor? That is a sound which comes during inspiration. Okay. So the child is breathing in. He's taking the air in. At that time, the sound is coming. Even in the OPD, when a child comes to me and he's sitting outside, I can detect stridor, which is audible. Okay. And I immediately get this child inside, get his saturation done. And in case if there are retractions and the saturation is 92%, then I, observe him in a separate observation room. This is croup, that is CROUP. This is, a viral infection where, it's also called as laryngotracheobronchitis, where the child has main three things. One is a barking cough, okay? Second is the inspiratory stridor, which I told you. And the third is hoarseness of voice. This is a typical triad. Why the voice changes? Obviously, because the larynx is involved and larynx is the voice box. So it's the hoarseness of voice. Why there is stridor? Because the larynx is narrow. So when the air goes inside, there will be stridor. And why there is barking cough? Because the sound of the cough which comes out from the opening of the glottis gives that particular peculiar barking type of quality. Okay. So, it appears as if a dog is barking. Okay. So you come across a child like this with inspiratory stridor and hoarseness. Remember, it is croup, also known as laryngotracheobronchitis. The trachea and the bronchi are also simultaneously involved. And that's why the large pipe, windpipe, trachea and bronchi, they are producing the sound which is coming out from the laryngeal opening. That's why that typical quality of cough. And of course, this is related to parainfluenza viruses in most of the cases. However, diphtheria also is responsible for, such a sound. Of course, there are other viruses which can also produce such a problem, but these are the common organisms, okay? And depending on the stridor and the retractions and cyanosis and the respiratory rate and whether the child is, dizzy, we divide this condition into mild, moderate, and severe. And of course, remember, you have to give a position of comfort. Keep the child in the lap of the mother. Don't disturb him. And in case, if it is possible for you to be in the OPD, say for about 3 to 4 hours, keep him under your observation. Or if you are not going to be in the OPD, please shift him to a hospital where you can observe this child or some residents can observe. Okay. And remember that steroid, particularly dexamethasone, can be given, and you can repeat the dose of nebulized steroid if previous dose was given more than 12 hours. Nebulized adrenaline is also given if the symptoms worsen. And if after 4 hours the child is asymptomatic, you can discharge and tell the parents, that these are the signs of seriousness. Okay. This is a dosage of nebulized budesonide 2 milligrams 12 hourly, and oral or intramuscular dexamethasone 0.15 to 0.3 milligrams per kg, prednisolone 1 to 2 mg per kg, and adrenaline 0.5 ml per kg, 1 in 1000 dilution, and maximum 5 ml. This is given through nebulization. Okay. And why do viral respiratory infections present so differently in children? That is because the airway is narrow. Okay. And that's why the resistance of the airway is, something which is inversely proportional to the diameter of the airway. So smaller the diameter, more is the resistance. Okay. Let's see another case. A 7-month boy brought with complaints of increased respiratory movements and difficulty in feeding. Okay. And he had earlier runny nose and fever for 1 or 2 days. And clinically, he had tachypnea, retractions. Okay. The chest wall is getting inside, and wheezing. So all these are important features, and this is bronchiolitis. I will tell you, in the beginning of my practice, I used to get such cases early in the morning in winter at 4 o'clock. Child would come wheezing, okay? Hale and hearty child, very chubby child, 10-month-old, breastfed, nothing else, not much of fever, but 2-3 days earlier has cold, and now he has started, wheezing and is breathless. This is because there is involvement of the small bronchioles. And remember, the receptors for cough are present in the upper part of the airway, like, in the trachea or the bronchus and, throat, larynx, and all. So these receptors are not present in the bronchioles. So these won't present with cough. They will present with breathlessness. Remember, so the presentation is with increased respiratory movements. The child doesn't come to you for cough. He has come for tachypnea, retractions, and wheezing. Okay, not cough. And this is a very, very common infection in young children, which starts as cough and coryza, leads to respiratory distress, fever, and tachypnea, prolonged expiration. That is because, the airway gets blocked, so the air finds difficult to get out. It can get in easily, but for going out, it takes time. That's why expiration is prolonged. And this particular child, is most likely to be having the infection with respiratory syncytial viruses almost in 80% of the cases. Okay. And these children, in case if have low oxygen, they need to be admitted. And particularly in case if, there are some high risk factors or there are some underlying cardiac or pulmonary disease, it's important that you admit them for observation, give them oxygen, nebulized bronchodilators, and supportive therapy. And there are people who use hypertonic saline, but the use is debated. There is also some role of nebulized adrenaline, but some of these issues are always in the medical discussion arena. And remember that there are some important principles when you manage viral respiratory infections. Number one, see that the child is well hydrated and well oxygenated. These two are extremely important. Unfortunately, when a child is brought to the OPD these days with respiratory infections or respiratory complaints also, they receive ABC, antibiotics, bronchodilators, and corticosteroids, which is not a good state of affairs. Examine the child, look at the respiratory rate, look at the oxygen saturation, see whether he is serious or not serious. See, whenever a child is brought to you, look at certain things. One, whether he is sick or not sick. If he is playful, well, non-sick, you need not worry. Number two, whether he needs some emergency treatment in the form of oxygen. See that. If he doesn't, well and good. Number three, look at him and decide whether he needs any tests like investigations, like hemogram. And number four, whether he needs to be treated urgently and hospitalized. Okay. So all these points should be at the back of mind, because in a busy OPD, it's important to classify. So see whether the child is sick or not sick. See whether he is, the one who needs to be observed or hospitalized, whether he needs some emergency treatment and investigations. And then you can very well take your time to take the history and diagnose and so on and so forth. Okay. So pediatricians must remember that in the OPD, they should differentiate viral from bacterial. As I told you, sneeze and wheeze is not bacterial. Number two, rule out whether it is influenza. And if it is influenza, start oseltamivir fast. If you find that no, it is bacterial, tonsillopharyngitis, tender nodes, you are very well justified in starting amoxicillin. Sometimes it so happens that the pediatricians are confused as to whether it is viral or bacterial. Under such situation, that scoring system will come to your help. Or there are pediatricians who use, the rapid antigen diagnostic tests for diagnosis of streptococci. If you are lucky enough to have this test, well and good. But not that all pediatricians have the facility, and they have to go by their clinical judgment. It's prudent and wise to, have your clinical acumen perfect and diagnose influenza or bacterial infection in time. But in case if you are going to use oseltamivir, please start it fast. I told you, whenever a child has symptoms suggestive of influenza in the epidemic setting, when your colleagues are getting so many cases, and when you have so many people in the community having influenza, it is better that you put the child on oseltamivir. There are many who hesitate to start this oseltamivir. Don't be worried about it. It's in general a very, very safe molecule, and you should be aware of the dosages. The dosages are all written in the product insert. And in children, you can give it in the form of a syrup, or in adults, you can give it in the dose of 75 milligrams capsule, one in the morning, one in the evening as therapy. And for prophylaxis, particularly those who have high risk conditions and there is a child in contact. See, influenza basically is a disease of children. And under the age of 5 years, the incidence is very high. So children can transmit it to the people in the family. So in the family, there's a asthmatic grandparent, or there is a diabetic grandmother, or a mother who is pregnant. So all these are high risk categories. So if a child has influenza, see that all these high risk chaps in the family, they receive oseltamivir prophylactically for 10 days. Here the dose is given once in a day for 10 days. Okay. And as I told you, influenza differs clinically from other viral respiratory infections, and one should remember that antiviral treatment for influenza should be initiated as fast as possible. Okay. In addition to the use of oseltamivir for influenza early in the course of illness, there are quite a few important preventive strategies like hand washing, for example. When you sneeze or cough in the hand, all the viruses are onto the palm. Okay. If you touch it to the laptop, if you touch it to the staircase, if you touch it, anywhere on the table or even the handkerchief, then all those viruses will spread. Remember that influenza is a highly transmissible disease, highly transmissible. Okay, some of these viruses are notorious, like influenza, measles, COVID. All these are having very very fast transmission. Okay, and that is why you have to be very very careful immediately. The incubation period is so short, within a day, 1 or 4 days. The incubation period of influenza is 1 to 4 days. So the child will infect others very fast, and that is why you have to see that you cough in the elbows. When you cough in the elbows won't touch any table or staircase. Okay, so cough in the elbows, keep other people at a hand's distance, so that even if you sneeze, the virus will not spread at a greater distance. Avoid handshake and always say namaste. Okay, and wash your hands frequently. Even after examination of a child, it's better that our colleagues wash the hands. And I would request you to use the mask in the OPD, because many times, in the pediatric OPD, children will directly cough onto your face, and if you are not protected, you will directly get infected. Okay, so all those important rules related to the hand, okay, like hand washing, using of handkerchief, avoiding handshake, saying namaste, coughing in the elbow, all these need to be followed along with repeated washing of the hand. Okay, so these are the important key messages for you, that try to differentiate viral from bacterial. And before you think of amoxicillin or amoxiclav, think of oseltamivir, because that is something much more common. Why? Because 80 to 90% infections are viral, and of them, influenza is one of the common viruses. So particularly in the season of influenza, you have to be very very clear. However, these days there is nothing like season of influenza, because rainy season is definitely the season, but otherwise in some other parts of country, for example in Chennai and in northernmost part like Jammu and Kashmir, the season is in the winter. Okay, and the seasonality of influenza over years has changed, and many times we get all year round cases of influenza also. Okay, so beware. We are all aware that allergies and infections are the main cause of respiratory illness in our community. Allergic problems will not produce fever. Allergic problems will come either as allergic rhinitis or allergic rhinoconjunctivitis, and it's a totally different ball game. What we are discussing is the viral infections. Okay, we have discussed about the different viruses, we have discussed about different bacteria, and we have seen the relative place of antivirals and antibacterials in the management of viral infections. So with that, I stop sharing my screen, and in case if there are any queries from our colleagues, I will be more than happy to answer. Otherwise, I hand over the proceedings to Dr. Prashant and Dr. Payal. Thank you.
Sir, thank you very much, sir. And this is even interesting thing. Though influenza is no more a seasonal. I mean, you can get influenza all around the year in different parts of the country, though.
Yes. Yes.
Yeah, actually, this was the question from many of the doctors. They said that, now is not the season, so we cannot prescribe a Celtamavir to our patients. But there are cases now, there's an entire wave of flu that is rising. So, doctor, if you can have your more insights on how this is not going to be any more seasonal, it is going to be all around the year. Like, we don't have to wait for the season to strike for a flu cases.
You're right. You're right. See, this seasonality is something which is very interesting. There are two hemispheres of the globe, the northern hemisphere and the southern hemisphere. Okay. Now, India comes geographically in the northern hemisphere. Okay. But the seasonality of influenza in India is like southern hemisphere. What does it mean? It means that, different countries in the world, they get influenza at different times. And WHO, the World Health Organization, receives the data, the information from different countries. And there are some regional centers, okay, which report the viruses to World Health Organization, particularly the influenza virus. And depending on the type of the virus in that particular year, WHO will direct or instruct the vaccine manufacturing companies to include that particular strain for that particular year. Okay. And I must tell our listeners that influenza virus has two important antigens on the outer surface. These are the hemagglutinin and the neuraminidase. Okay, so hemagglutinin is of about 16 to 18 types, and neuraminidase of about 8 or 9 times. So you can get either one H and one N, so that will be H1N1 or H3N2. So one type of H antigen with one type of neuraminidase N antigen will make one influenza virus. And every year, the structure of the H or the N, will show a little change. Okay, little change. And that is called as a drift. Okay, that's why every year the vaccine changes. But once in a while, maybe, we have had 4 pandemics of influenza till now. So in 2009, I'm sorry, to 1919, then 1957, 1968, and 2009 in sequence. These pandemics have, created a lot of problem, lot of havoc all over the world. Okay, these strains, they continue, but now
Mm.
that H1N1 strain of 2009 continues to circulate in the atmosphere. Now that's not the major strain. Now H3N2 appears to be the major strain, even though that 2009 strain does continue. What I'm trying to say is that the strains will show little change, every year, and so the vaccine changes. And it is important that our colleagues also know the mechanism of action of oseltamivir. Whenever the virus attacks the respiratory system, it will first try to attach to the respiratory epithelium inside. Okay, it will go inside from the mouth, it will go down to the trachea or the bronchus, and then it will attach. This attachment is through that hemagglutinin or the H antigen. Okay, and once the virus gets attached, the RNA of the virus, the genetic material of the virus, will enter inside the human respiratory epithelial cell. Once it enters, it will dictate the DNA of the respiratory cell to produce similar copies of its own, like RNAs, RNA. So all the RNAs of influenza will be produced, and they will be ready for release out of the respiratory epithelial cell. But the neuraminidase enzyme of the influenza virus is the one which allows, or helps the virus to release these viral particles outside. And oseltamivir is a neuraminidase inhibitor, so it will block the release of the virions from the respiratory epithelial cell. Okay, so earlier you give, the molecule will block the release of the viruses, and that is how it spreads the viral transmission as well as severity of the illness in that child. So these are different aspects related to H and the N antigens. These are glycoproteins, and that's why it is important that our colleagues are aware of two facts. One, that the seasonality of influenza, which no doubt it's true that it's more in rainy season, but now the epidemiology, the seasonality is slowly changing, and now we are getting cases of influenza year round. Okay, with some areas, particularly the western part of India, we have those cases more in the monsoon, but the southern and the topmost northern will have these cases more. If you see, these are the areas where monsoon also comes late. You know that in Chennai monsoon comes, somewhere in
October.
December.
Mm.
Yeah,
October.
October.
Yes.
So in October, November, we have more cases there. In
Correct.
Kashmir also, they are at the same time. So these are the, influenza, and all these information that I am trying to tell you is very interesting. And it's a virus which has its own peculiarities, which are, to be understood. And once our colleagues understand the basis of the medical, features as well as the therapy, they will
Mm.
be able to treat patients with a lot of rationality. Thank you.
Thanks so much, sir. Thanks for your insights. I'm sure it will help the audience who are wondering whether the epidemic is all round or epidemic is seasonal or what to do during non-season. I'm sure the audience. Anything more, Payal?
No, I think this explains all. The webinar
Explain.
was exceptionally very informative and something new that we got to learn, that flu cases are no more seasonal, they are perennial.
Absolutely.
Wonderful.
Thank
Thanks,
you.
doctor. Thanks all the
Thank you.
doctors who took time from their schedule and attended this webinar. Thanks, Dr. Zog, once again for this insights on oseltamivir and influenza. And thanks IT team, marketing team, and sales team of ITRO for coordination. Thank you very much. So we can sign off. Wish you a very pleasant afternoon. Thank you.
Thank you.
Thanks, Payal.
Yes, sir. Bye-bye.
Thank you. Thanks, Sanjana.
Thank you, Sanjana.